Afternoon, everyone, and thank you for joining us today at Harvard School of Dental Medicine. It is my honor and privilege to welcome you all in our esteemed panel to the Professor Donald Giddens Research Day. And as part of Research Day, we have our esteemed panelist, Dr. Richard Watt, who is the commissioner of the newly formed Lancet Oral Health Commission. And in celebration of Dr. Watt and the new Oral Health Commission, we have assembled a panel of Lancet experts, commissioners in interdisciplinary areas to talk with us today in a conversation that will be moderated by Dr. Allan Brandt to learn more about what is a Lancet Commission, how do they work, and what might the expected impact be. So allow me to introduce, and I will do this alphabetically, Dr. Rifat Atun, who is Professor of Global Health Systems at Harvard University, Faculty Chair for the Harvard Ministerial Leadership Program, and Co-Chair for the Lancet Diabetes and Endocrinology Commission. Dr. Gene Buckman, who is Director of the Program in Global Noncommunicable Diseases and Social Change, Assistant Professor of Global Health and Social Medicine at Harvard, and Co-Chair for the Lancet Noncommunicable Disease and Injury Poverty Commission, and Dr. Margaret Crook, who is Professor of Health Systems, Director of the Quest Network, a multi-country network looking at quality health systems. She is Chair of the Lancet High Commission on High Quality Health Systems. We have Dr. Vikram Patel, who is the Pershing Square Professor of Global Health at Harvard Medical School and Co-Chair for the Lancet Commission on Global Mental Health. He will be joined by Professor Saxena, who is his co-chair of global for the Lancet Commission on Global Mental Health and Sustainable Development. And they have both been on the Lancet Commissions on Global Mental Health in 2007 and 2011. Finally, our honored guest, Dr. Richard Watt, who is Professor of Dental Public Health, Department of Epidemiology and Public Health at University College London, who is co-lead of the Lancet Commission for Global Oral Health and Director of the WHO Collaborating Center on Oral Health Inequalities. And I'm also pleased to introduce Professor Allan Brandt, Professor of the History of Science here at Harvard and Interim Director of the Harvard Global Health Institute. So Dr. Brandt, if you would please, thank you.
Thank you so much, Dean Barrow. It's really a pleasure to be here today and to have this chance to moderate such an exceptional panel. As Dean Barrow mentioned, the instigation for today's session is the really impressive commission that Dr. Richard Watt is now leading on global oral health. And I think many of you in the audience are probably at this point familiar with the Lancet Commissions that have been generated by the Lancet's incredibly notable and impressive editor, Richard Horton. And these commissions, now there have been more than 70, have looked at the most critical issues in global health, medicine, public health, and social medicine. And they have become a widely recognized and influential mechanism for drawing attention to the most serious problems of global health, health disparities, areas of health that have often been neglected and often not part of traditional or even serious medical, dental, public health training. And so these reports have become a notable aspect of the global health environment and ecology of the last 2 decades. As a historian, I thought this is a great topic for a doctoral dissertation. What does it mean to do a Lancet Commission? What is the process by which these commissions do their work and report their findings and attempt to influence policy and practice around the world? So these are some of the questions that we want to address this afternoon, I was thinking also that the history of reports and commissions is one of the deepest aspects of global health if we really think back. And in a way, Edwin Chadwick's famous study of the sanitary condition of the laboring populations of Great Britain, 1842, is something of a model for the way we today consider doing this kind of work that can shape and influence, and in ways that we hope, as Dr. Watt explained in his very impressive lecture this morning, can be bold, transformative, and really change the actual characteristics of health and disease across the globe. So we'll start today with Dr. Watt, who is leading a commission on global oral health. And then we'll turn to our several Harvard colleagues who have been deeply involved in the processes of leading commissions, working on Lancet Commissions, to get some of their observations about the process, the problems, the opportunities, and the outcomes of the work that they're currently engaged in and the several commissions that they have participated in the past. So it's a real great pleasure for me to introduce Dr. Watt. I attended his Giddens lecture this morning, and I urge all of you who didn't have a chance to be there to take a look at the recording of his very important lecture. Dr. Watt.
Thank you very much, Dr. Brandt, for that very, very kind introduction, and thank you, Jane, for your kind words also. It's a great pleasure for me to be involved in this discussion. I think it's such a brilliant idea to bring together people from across Harvard with experience of Lancet Commissions, because as Allan has just described, I'm a new kid on the block. I'm just starting up, really, and I really would like to ask you, as other panel members, lots of different questions in terms of your insights and experiences. But perhaps what I could do to begin with is just deliver a few short slides to sort of set the scene for my journey so far. So if I just share the screen and let me just put a couple of slides up. So I'm co-lead of this newly formed Lancet Commission on Oral Health. Now, because of the pandemic, we actually had our first meeting last year, but things have been slightly delayed because clearly communication, face-to-face meetings, travel have all been severely curtailed because of the pandemic. But having said that, we are very much ongoing and started up as a commission. And our commission really, the origins of our commission were from a series of papers that were published in the Lancet in 2019. Now, for the other panel members with much more experience of working with the Lancet, you probably don't remember the excitement and thrill that you had when you first published in the Lancet. But for me, that thrill and excitement is still sort of palpable in my circle. And we had a really very positive experience of engaging with the Lancet editorial team, with Richard Horton and other members of his staff. We got oral health onto the front cover of the Lancet, which was a pretty major landmark for many of us. And what I think we did was quite simply give a simple narrative about the global public health importance of oral diseases. Just chatting before we started, there are some similarities between oral health and mental health in the sense of, they're recognized as important health problems, but often quite neglected, quite often low profile in terms of prestige and priority in many areas of medicine. But what we did in our Lancet series of 2 papers was really highlight the global public health significance of oral diseases in terms of prevalence of conditions globally, and a sort of key advocacy message, based on the global burden of disease data, latest surveys, at least 3.5 billion people around the world suffer from oral diseases. So a significant number of the global population experience these conditions. What we also explained in our narrative was the socioeconomic inequalities that exist with oral diseases, the social gradients, the ways in which oral diseases are particularly impactful amongst marginalized and socially excluded groups. And I think that rang true to the Lancet's interest in equity, in global equity, and oral diseases are often conditions that are very visible and socially stigmatizing in communities. So that message really came through very strongly. What we also did was pull together the international global data on the impact of oral conditions on morbidity, mortality, the whole range of individual societal impacts of oral diseases. Now, amongst professional middle class people, many of us will have a good oral health. You will not have experienced the pain, discomfort, social stigma, costs, etc., associated with oral diseases. But now that evidence base is there in terms of high quality studies. And what we managed to do really is emphasize the impact of oral diseases that are largely preventable, but are major impact on individuals, society, and community more broadly. And what we also did, which again really resonated with the editorial Lancet team, was highlight, I think what Richard Horton calls the villain in the room, the influence of big sugar as a commercial determinant of global health, and the power and influence of certain sectors within the sugar industry globally, and their ability to influence and determine policy, training, research priorities, etc. So again, I think that had a strong interest for the Lancet. It caught their attention. The final thing that we did in our papers as a sort of backdrop is critically reflect as a group, and all of us were dentists who were involved in this paper, in the failure of our current systems around the world in terms of how dentistry has been delivered. And again, this morning we discussed this, but one of the biggest challenges is dentistry has become marginalized, separated, compartmentalized from general medicine. And that is a historical fact that's taken 150 years or so for us to get here, but that is a major obstacle for improving global health more generally. So what I want to really do is to finish now that as a group of us, we've now got 37 commissioners from 17 countries around the world coming together, many of them from medicine, from public health, from global health, as well as oral health backgrounds. And what I'd really love to hear now from the other panelists is their experience of using the opportunity to work with the Lancet on a commission that really gains traction in terms of policy change, system-wide transformation, and how to be as bold as we possibly can. So the insights and experience from others, I will really very much value and look forward to hearing the perspectives from my colleagues. So that's me finished. So I'll stop sharing now.
Thanks so much. That is a great overview of the critical issues that oral health raises for global public health. I couldn't help but think when I heard your lecture this morning that in one sense, oral health is such a powerful, we might say, biomarker for general health overall. And the more impact you and your commission have, I think would be reflected in many other critical health indicators. So thank you very much. Let's turn now to Dr. Gene Buckman, and he can explain some of the work he has done on Lancet Commission reports.
Thanks, Alan. So, Alan, it's funny. You were mentioning, history, and I was just sort of reflecting on the first meeting that we had of our commission on NCDs among the poorest billion, and Rifat was there as well, and Margaret, I believe, as well. And we were all staying at the Grange, St. Paul, and there was a first dinner that we had the night before, and we were, it's a beautiful view on the balcony there of St. Paul's Cathedral, and I remember Richard Horton talking about, I had sort of started with this thought that, was it really appropriate to have a commission that's focused on, people living in extreme poverty in this really opulent place in London. And he kind of recalled that the symbolism, I guess, of that cathedral that had been built by Christopher Wren after the older cathedral had been burned down in the Great Fire of London in the 17th century, and that it had kind of marked the end of the plague years in England, and really the start of the scientific revolution that spread from the UK to the rest of Europe. And so there was this symbolism of fires and revolutions that seemed kind of appropriate. I also, in advance of that talk, I had it's an easy thing to do, but it felt neater than, I guess, in 2016, just to look back in the Lancet archives of where the commissions actually started. And I actually found that they go back to the 19th century, and I use these slides in the talk that I gave at the time. But I think it's interesting to sort of share this here. So these were the slides that I showed at the time, and one of the things that's interesting is that, of course, Thomas Walkley, the founder, the editor of the Lancet, was quite a rabble rouser himself, and that's sort of what characterized a lot of the commissions, is that they're disruptive. And I used to know more about his personal history at the time, but the stuff that I found in terms of the original Lancet commissions, a lot of them were fairly amusing. Like there was this kind of stuff like, and really they're mostly like this. There's one on an analytical sanitary commission on the manufacture and characteristics of Munich lager beer. There was one on Burgundy. There are quotes like this: German beer, more especially the Munich beer, is undoubtedly becoming a very popular beverage in this country. It's not heady. Those who cannot do sedentary or clerical work after taking the strong and heavy English ales and stout are not inconvenienced by drinking lager beer. There's one on special commission on Sicily as a health resort. So, I think I think it's an interesting reminder, and there's certainly there's a bit of a risk of that in the commissions, that sort of like contrast between the seriousness of what they're addressing in this kind of history. But for me, in the early 2010s, I remember being on a plane and having a bucket list, and it was on my bucket list to just publish something in the Lancet, anything. I don't think, and I don't think I ever would have really imagined that I would have been part of a project like this, and it was really, really exciting to be able to do something like this. And for a lot of us, I think, as we're as academics and public health practitioners, we're often like in internal debates with the Lancet, that is, in the sense that to the extent to which it's the forum in which a lot of positions in global health are expressed. I think that we're in debate with it, and I think that for some of us that were involved in this commission, we were in debate with a picture of non-communicable disease or chronic disease that the Lancet had actively participated in constructing as a category. And this was like another, this was like a cover of a Lancet series on chronic disease that had come out, you can see around 2010. And that some of us felt was making invisible this picture of what non-communicable disease and injuries were like for the world's poorest people in its diversity and complexity. And we also felt that the way that UHC was beginning to be framed in global discourse and within other work that had been done was incomplete, and was also kind of creating this gap and making this part of the disease burden invisible, and was perpetuating this idea that really for the poorest people in the world, essentially this is a MDG type agenda with maternal newborn child health and major infectious diseases being still sort of the major focus even in the SDG era. And so the real intent of this commission was to disrupt that position. And in this initial talk, I kind of had this Venn diagram, of where the traditional NCD agenda was, and where the burden of disease for the world's poorest people were, and roughly like what these proportions were. And so, in the end, some of the major work that we ended up doing in the commission was to actually quantify, what this relationship was. And I think that one of the reflections on that is that although, we did, lots of work. I think we counted something like, there in the 20s of, in individual original research outputs that went into this commission over some, 4 or 5 years. In the end, there's a pressure, not a pressure, I'd say like for a communication standpoint, it's nice as if you can have quantitative statements that are novel and that can be communicated in a tweet, can be communicated to the press, et cetera. And for better or worse, one of the best tools to do that is the global burden of disease study and manipulations of it. If you want to make kind of global statements, often I think we end up going back to that. And I think that's something that in your commission, Richard, that you'll, I think, struggle with in terms of how are there other ways of making statements, and very clear quantitative statements that that they go beyond some of the limitations of GBD. So that's one of the things that I've thought about. The other thing, just briefly, in our commission that we did from the beginning that was difficult, but in the end we did it, was that we in parallel supported in the end something like 16 national commissions that had a similar structure to the global commission in countries. And that is one of the reasons why why our commission took 4 or 5 years, but in the end that has been the foundation for a network that now includes 23 countries, and that's in a position to support the implementation of the Commission's recommendations, and has been a great asset in terms of translating the movement really that you're building in the process of developing one of these commissions into something that has impact for for people. And I think that that's also something that you'll want to ask yourself, about how much do you want to get into these kinds of things that make it more challenging to actually complete the work of the commission itself, the report itself, which is in and of itself is challenging, because you're doing internal peer review with a large number of people that each of which have veto power, and then you're also going to be dealing with external review, and then regaining consensus with that same group of people after reaction to both internal, external review from the Lancet, external review from peer reviewers. So, staying focused on getting through that process is also really important. So back to you, Allan. I'm happy to talk more, but I thought that would be a good start.
Thanks. I just had this observation because I learned so much from the, Non-Communicable Disease Commission and your work. And, we've tended to treat non-communicable disease and infectious disease as a dichotomy. And one of the things that I really learned from your report, and now we know it regrettably all too much, is the relationship of infectious disease to non-communicable diseases and the risks that that poses. And we've really seen that over the last year. So I'm very grateful to you for these comments. I should say that we're going to be very eager to take questions from all of you out there in the electronic webinar world. So please feel free anytime to post a question in the chat, and we'll try to get to it when the panel is complete. So let me now turn to Dr. Margaret Crook, who has also had deep engagement in the Lancet Commission process. Margaret.
Thank you so much, Professor Brandt. What a pleasure to be with you all today. And I will briefly speak about the Lancet Global Health Commission on High Quality Health Systems, which published in 2018 and has had quite a tale of results and hopefully impacts that I'll just briefly mention as well. So our commission, which was known as the HQSS Commission, started really from this simple frame, which is that a lot of the focus, particularly in lower and middle income countries over the past few years when it comes to health systems, has been on driving utilization of care, ways to increase utilization through expanding network access, clinic access, motivating folks through education to use healthcare when need arises, and preventively, with the idea that that over time we would add quality to this equation. And we sort of questioned, the commission started with the question of where is the quality in this equation? In fact, what does it even mean to produce a high quality service in a low income setting? Because we felt quite certain that health service of insufficient quality cannot result in health. So this was the premise of our commission. We spent quite some time clearly articulating that with the idea, again, that this is not a nice to have 20 or 50 years out, but rather a must have now in order to be able to proceed to better health outcomes. So the Lancet Global Health Commission on High Quality Health Systems was the first commission launched by Lancet Global Health, which is the journal, the Lancet Family Journal that focuses on global health. And it had three goals: to define quality of health systems, describe its state, and then to think about measurement as well as improvement. So what is the state of measurement of quality, and what is the state of improvement, and what can we do differently? I think this has already come up in discussing Lancet Commissions more generally, but one of the key value propositions of Lancet Commissions is to sort of survey the field and summarize where we are and potentially signal a direction for where we ought to be going. And I think we took that charge quite seriously in starting a fresh sort of, I shouldn't say afresh, of course, building on the great amount of work that has gone on quality in both the United States and throughout the world, but really trying to update it for the current era and survey, where we thought there were deficiencies and suggest solutions. So our timeline, our commission probably took about 1.5 years, just under 2 years to deliver the report, which was in 2018. We had several launches of the report, and that's part of it was a very deliberate part of our strategy to speak to different audiences. We had a sort of broad public launch in Washington in September of 2018. And then we had a launch more for academic colleagues working on health systems at a conference on health systems in Liverpool in October of that year. And then we follow that up with global national launches. We, like Gene, had national commissions. In our case, we had 9 national commissions that were doing their own deep dives into quality in their own setting. We ended up working with them to do large-scale events in 5 countries at the conclusion of the commission to share results with policymakers and researchers. This is our commission. We had 30 commissioners from 18 countries, and we explicitly chose commissioners when I began this. Explicitly chose commissioners who were not all academics at all. In fact, we wanted people who were tasked with driving health systems forward, with difficult decisions on financing, where to put money in health systems. So we had a combination of Ministry of Health officials, politicians again, Minister of Health roles, technocrats within ministries of health, and of course academics. But I always had this perspective that academics can always be brought into commissions through commissioned papers and collaborations. But as far as choosing commissioners, it was just important for us to have kind of some real world experience with this topic, because they are ultimately the audience for the findings. I should say that my co-chair was Dr. Mohammed Pate. He's right here, and he is now the head of health, nutrition, population at the World Bank. What's also absolutely vital for any commission to function is the research team. And here is just a snapshot of some of the researchers, mostly at Harvard, this team, who were there working with me at the Secretariat. And we had many researchers across many other countries who were working on this part-time, and some of these folks were also part-time. But just to say that nothing would have been possible without the consistent daily efforts and intelligence and creativity of this group of folks. So what you see here is the cover of the commission report, which was published as a separate publication by Lancet Global Health. We were obviously thrilled to see this. I remember still getting the pack of copies and saying, wow, it's pink. How did it end up pink? But these are not things we had control over. Actually, I'm fond of it now. I also was surprised for the first time to see the quote that the editors of the Lancet pulled out as the pull quote on the cover, which we very much stand behind, but it was just very interesting. Editorial decisions get made not entirely and all in the control of the commission chairs. So I want to say just a little bit about what we thought were the key contributions of the commission and how we organized our work according to those priorities. We felt quite strongly that we needed to start from basics. So definition of the issue. So what is a high quality health system was a real starting point for us. A lot of debates within the commissioners. Are we avoiding low quality care, for example, or are we trying to draw a future here in which everyone is entitled to some minimum quality? And we had spirited debates about which way to go, and ended up really focusing very much on the aspiration and not on the avoidance of the worst case scenario. So you can see here in the definition the ambition around improving health, of course. But also much broader, I think, than some past definitions, a focus on people and generating value and trust among populations as a key feature, really a key attribute of a high quality health system. And the last one, of course, is the ability to be elastic, the ability to be adaptable. And I think we don't need persuasion about the importance of that. But we, again, bake this right into the definition of what is a high quality health system. So much, I would say this is much broader than other definitions of quality of care, which typically have to do with the patient provider experience. As Gene said, I think it was essential for us to put some numbers to these concepts. And we spent a lot of time trying to estimate how many deaths might be excess deaths that wouldn't have happened. Might be due to poor quality care, and how increasingly it is not a lack of access, but rather a lack of quality when people get to clinic that is responsible for excess mortality. So our estimate was there are about 8.6 million deaths every year that are amenable to healthcare in one way or another in low and middle income countries, 137 countries. Among those, the majority now already in 2018 were due to poor quality rather than underutilization. So people are coming to care. And the question that we asked in the commission is, what are they getting? Well, they're not getting better. That's what we can see here. We also were very careful that our commission was not disease specific, but really looked across the board at health systems. Our byword was constantly the health system. What is the health system responsible for? And we took a very broad perspective, which was quite interesting because a lot of the quality discourse up until that point had been very much nested within disease conditions. We, as I mentioned already, I think a lot of the power of this commission lay in the involvement, well, hopefully in the rigor of the work and the breadth of the work, but also very much in the involvement of high-level figures from a number of countries. These are the countries in which we had full-scale, sort of large-scale launch events, which, for example, in India included the health minister, the secretary of health, and representatives from all over the country coming in to discuss what the implications were of the commission's findings for their state. On the issues of measurement, for example, on the issues of improvement. So we had commission launches, separate commission launches, and these discussions. We didn't, in fact, call them launches. They were consultations, which is very much what they were. So the local commissioner would take the lead. We would then have extensive consultations with stakeholders, Ministry of Health primarily, and other stakeholders about what this implies in Argentina, in Kenya, in Nepal, in India, and Ethiopia as well. And those, I think, were really quite important. One thing that's very clear is, although the Lancet journals are highly prestigious and, of course, publish great work, being in the country and being able to speak to people about how these concepts apply, to me, was far more meaningful. You could just feel that impact at a very different level than just simply sending the pink report, which we did, of course, as well. I think that's the end of my slideshow. I'm happy to take questions when the time comes, but thank you so much again for having me.
Thanks so much, Margaret. I couldn't help but think in my sort of focus on false dichotomies that the issues of access and quality, which has often been broken apart in that way, is such a, self-defeating false dichotomy in our thinking about health systems. So I think the report you did is so important. We're getting some great questions in the Q&A, but I think what we should do is move on and complete our presentations, and we'll go back to some questions that are focused either on specific reports or Lancet commissions more generally. So our next speaker is Dr. Rifat Atun. It's great to have you here, Rifat.
Yes, thank you, Allan. Right, thank you, Allan, and thank you, Jane, for the invitation. It's a real privilege and honor to be part of this distinguished panel of friends. Many of whom were involved in Lancet Commissions with me. I want to provide an overview of my experience and explore some of the impact some of these commissions have had, the commissions that I've been involved with. Gene mentioned the Lancet Commission on the NCDIs of the poorest billion. I've had a chance to be involved in 10 Lancet Commissions to date. 10th one is actually in press, and I'm currently involved with 2 others. I must say they're great fun. They come with problems, but they're really wonderful platforms to bring people from very different backgrounds to explore major issues that are pertinent to global health. But it's also a great way of getting to know colleagues, keeping up with the literature. With each one, I've learned a great deal. And these commissions have ranged from a very eclectic mix of the Lancet Commission on Technologies for Global Health, which I did when I was at Imperial, actually, and the Lancet Commission on Women and Health with Anne Langer and Felicia Knoll, the Lancet Commission on Palliative Care, and then recently a series of Lancet Oncology Commissions on expansion of global access to radiotherapy, on access, improving access to children with cancer, and recently on Lancet Oncology Commission on diagnostics and nuclear medicine for cancer. But I will very briefly focus on the Lancet Diabetes and Endocrinology Commission, which I was asked to do. This involved around 65 collaborators in the commission, and including 30 or so researchers. We had PhD students, DRPH students, as many MPH students who were able to actually visit countries and undertake the research there. And this was the first commission of the Lancet Diabetes and Endocrinology, and the first one to focus on Sub-Saharan Africa specifically. As a process, it has been quite influential. I'll tell you some of the outputs from this work. But one of the things that we did with this commission was that, in addition to the report, we generated several outputs that were very easily accessible, such as infographics, as well as videos, podcasts, and the video that actually the Harvard communication team developed, which was very easy to follow and understand. So what are the lessons? And I've reflected on this and came up with 10 lessons, 7 F's and 3 O's. The first is important to have real focus, to be really distinct, focus on an area of major need, and focus on a geography or population group or an age group. And then the commission should be novel, either in framing of an existing problem, use of new data, or new analytic approaches. The form is important. We need to ensure that the commission is multidisciplinary, and the form and the structure will vary. One has to be flexible, reflecting evolving needs of the commission. It should be non-hierarchical. I've been in commissions that were very flat, but also others that were very top-down, and they did not work as well as a commission. And typically, one would have multiple working groups, research teams, and it's always useful to have an advisory group, including engagement of civil society groups, but also in some cases, a broader set of stakeholders who can bring on board their views that can be incorporated into the work of the commission. In terms of the function, it's very important that the commission functions as an engaged and integrated team, rather than a collection of people who meet irregularly. And the commission needs to empower everyone, needs to engage everyone with regularity. So one needs to have routines, and everything needs to be transparent. Otherwise, there's a danger that the commission gets taken in a particular direction. Fairness is important. The membership should be inclusive, should be diverse and representative. It should be global and balanced. Civil society engagement is critical, because at the end of the day, it's the patients who are going to be beneficiaries of the output of the work. And one has to distinguish, I think early on in the commission, who the commissioners are versus who the researchers are versus who the contributors are, and what role they will play in relation to the authorship. Financing will vary. I've been in commissions that have received no funding, and others that received substantial funding. The funding, one has to be careful, because with philanthropic organizations, they can try and pull the commission in a particular direction to reflect their own priorities, as opposed to the priorities of people that the commission output should benefit. One problem I've experienced is free riders. One starts on a journey, then some people join the group, then they don't contribute very much, but at the end they appear, and it's very challenging to decide what to do with them. So I think upfront it's very important to establish criteria on who's going to be included in the final authorship, and also beware of latecomers. I've been in one, I've experienced occasions where after 3 years of work, some individuals have come in and they've ended up being in the sort of author list. So that leads to fallouts and tensions in the group, which needs to be very carefully managed. And I also had instances where some individuals actually, that was not with a commission, but with a series, where some individuals walked out because the fallouts and the tensions were not well managed by those leading the work. So very important to think of these issues up front. And the way to overcome this is to engage everyone on an ongoing basis with real transparency and ensure all views are taken on board and maintain objectivity. But one has to sort of take a firm position in terms of sort of contributions. Next, the eighth principle is the output. Again, commissions, they need to be driven by rigorous scientific work, but the report needs to be accessible to multiple audiences. So one might want to have a publication strategy, combining the report output maybe with a series of sister publications, maybe including even methodological publications, so that the report is very accessible to multiple audiences, because one really wants to influence policymakers, programs in the countries, and funders to try and get traction for the report output. And the output should be usable in addition to a very accessible report. Important to use infographics, podcasts, videos, and animations. Now, outreach is very important. Again, as Margaret mentioned, and also as Gene has done, one should use multiple fora and platforms. Media is very, very important. Country engagement is critical before, during, and after the commission. There's nothing worse than going to a country and presenting a commission where people will turn down and say, oh, really, were you doing a commission? We didn't know anything about it. So very important that this engagement begins upfront when the commission starts, not at the end. And partnerships are critical, partnerships that include funders, civil society, and international organizations. And outcome is really what we are interested in. Report is the end of the beginning. The commission's work ends, but actually this is when the real work begins. Very important to think about establishing a program of work and a coalition to implement the findings. This is key. So follow-up and reviews is critically important. With two of the commissions I'll mention in relation to outcome, with the Lancet Oncology Commission on Radiotherapy, which for the first time was able to quantify the need for radiotherapy globally, including unmet needs, and the cost and health and economic benefits scale up to demonstrate return on investment, was quite influential. The report was picked up by multiple media around the world, and we've been working since with UICC and also with International Atomic Agency Authority to use the report to influence countries. We've also used the Global Task Force for Radiotherapy to establish a global network, global RT, that actually works with countries and also trains a group of leaders, future leaders, to increase uptake of radiotherapy to improve cancer outcomes. And with Lancet Endocrinology, a real excellent output has been the Global Health Population Project on access to care for cardiometabolic diseases that now involves about 20 universities, 50 or so collaborating countries, and more than 80 researchers with a very rich program of work. And many of the outputs are currently being used by WHO to influence their management of Ncdi policies. Thank you very much for the opportunity, and I look forward to the discussion.
Thanks so much, Rifat. I can't help but reflect that there's probably no one who has so much experience, and these observations are incredibly valuable. I have to say, as somebody who has spent my life doing academic work, I think that the issues of audience and impact are often not where many of us have our expertise, and yet they're so critical to the potential influence of these reports. And I'm especially pleased that you emphasized those issues as well as many others. Our final speakers are Dr. Vikram Patel, and I think Dr. Shekhar Saxena is also here, which is great. Vikram is a colleague of mine in the Department of Global Health and Social Medicine, and he also has been involved in several Lancet Commission reports, especially those centered on the enormous issues of global mental health. It's great to have you on the panel, Vikram and Shekhar.
Well, thank you, Allan. First of all, I want to start by acknowledging Richard's opening remarks about the similarities between oral health and mental health. And also, many of my remarks will be in line with what Gene and Margaret and Rifat have described. The story of our commission actually really begins well before the commission was actually published. And I think it's important to share this backstory. Way back in the early 2000s, mental health was never seen as a global issue, except by a few agencies like the WHO. And certainly no leading medical journal would devote even maybe a page to mental health, seeing this really as a peripheral matter. It took the vision of Richard Horton as the editor of the Lancet at that time to respond to Shekhar and my message, asking whether he would consider a series that synthesized the evidence on mental health in the global context. Shekhar will remember well, he replied within, I think, a few hours, and we were absolutely astonished that the Lancet would actually consider a full series of articles. This series of articles was very, very, very important historically because it really laid the foundation in many ways of the principles of the field of global mental health by identifying some of the major challenges and crises, particularly the unmet needs for care, but also the human rights abuses that people with mental health problems were facing across the world, including in wealthy countries. It laid the foundation for what then became known as the Grand Challenges in Global Mental Health, a major research funding initiative led by the NIH, which my back of the envelope calculation suggests that at least nearly $1 billion of new money has been made available in those last 8 or 9 years, leading to a flourishing of implementation science evidence that really sought to address the challenges that the Lancet series had identified. So this is just an example of what a series of articles in a journal can actually do. It just shows the power of the Lancet as a home for these sorts of articles. Thanks to that evidence, we now know today how we can deliver a whole range of interventions for mental health, preventative as well as clinical, in any resource setting. Back in the early 2000s, it was generally thought that mental health care was fabulously expensive. It wasn't that effective to begin with, and therefore no country outside the wealthy world could actually afford mental health care, so we may as well park it in the cupboard. But now, thanks to the series that led to the Grand Challenges, we now had more than 100 randomized control trials testifying that there were innovative and different ways of reaching the last mile when it came to mental health care with very effective interventions. That evidence transformed mental health globally. And so these are just examples of national policies. For example, the National Mental Health Policy of India. Shekhar, of course, has been central to the World Health Organization documents such as the Mental Health Action Plan, the World Bank's Disease Control Priorities Program, as well as the more recent independent high-level commission on NCDs, which embrace mental health. If you look at these reports, all published in the last few years, you will see this flourishing of evidence now being synthesized into policy recommendations. But the truth remains that actually on the ground, very little has actually changed. As Tom Insel often, in his forthcoming book, he was a former director of the NIMH, says in a forthcoming book, in spite of $20 billion of spending on research by the NIMH in the 10 years that he was the director. In the US alone, mental health, the burden of mental health problems has risen 40% in the last decade. Suicide rates in young people has risen by 50% in the last decade. And the situation in developing countries is even worse. So it seems almost as if in spite of all the advocacy and science, we really haven't shifted the needle. And so this is really the background to the commission. This was the raison d'etre for the commission, that it was really to interrogate why 50 years of research and advocacy had yielded such little action, and indeed such little transformative insights, which can shift the needle on the burden of mental health problems. and of course, the enormous unmet needs for prevention care, which were not only huge, but are increasing. The commission was published in the Lancet in October 2018. And I think an important point that we chose to do was to strategically align the commission with the Sustainable Development Goals that had been recently been published or approved or ratified in about a few years before. And we thought it was important because we felt that one reason for inaction on mental health was that people really saw this as an intangible peripheral issue. Richard, this might be also similar to oral health. So, all the governments in the world were seized by the Sustainable Development Goals, and we thought strategically that this would be a very important ploy to actually get them interested in mental health. And we also coined this slogan, no sustainable development without mental health. So here is a list of commissioners. Shekhar has joined me here, who's now a colleague in Harvard. And you can see a group of very different backgrounds, very different countries. So this is a key. And of course, Allan, you'll also recognize our fellow colleague in the department here. So I'm not going to go through these messages, but it's really important for me anyway to emphasize that a commission isn't necessarily producing new science. At least not our commission did not. I mean, there's a new way of looking at an existing problem through an interdisciplinary lens by bringing together evidence that has been there, but which has not been fully embraced by the broader community. And so here you can see some examples of ways in which we have reframed or reimagined mental health care. I think the first bullet point is particularly true for mental health, maybe more true than virtually any other health condition, that actually this idea of global health, which is a euphemism for people out there in some kind of backwater of Africa or Asia, actually is also true of downtown Boston or parts of the US. In fact, it's true of almost every developed country. And so in many ways, our messaging was not only for the developing world, but actually for all people in all countries. We also took on and challenged the prevailing dogma about mental health problems being narrowly defined as they were in diagnostic systems. We took on the dogma that we couldn't do much for prevention, which in fact was completely false. And we demonstrated through the evidence, actually, we can do a lot for prevention, but those actions lie outside the mental health sector. We embrace fully the issue of human rights, and really put ourselves out on a limb when in comparison with the mainstream psychiatric community, emphasizing our complete agreement with the Convention for the Rights of People with Disability on the issue of violence and coercion in mental health care. And of course, we really positioned the implementation science evidence that I mentioned earlier had flourished as the foundation of what mental health care should look like, which was really empowering communities in the mental health care delivery system. There's been a lot of impact. I'm not going to go into any of these in any detail, but suffice to say, the key areas you can see here is impact outside the narrow mental health sector, for example, for people with a lived experience and with policymakers. But for me, coming to Harvard in April 2017, this was also an opportunity for me to examine how my program of work in Harvard could be influenced and shaped by the commission. And in fact, our cross-university initiative that was launched in 2018 was completely inspired by the Lancet Commission. Today, we have 5 major work programs, and all of them are actually specifically aligned with the recommendations of the Lancet Commission, including 2 new short courses that are jointly offered at HMS and HSPH, which really teach what the Commission has synthesized. In ending, I just wanted to share some key features which made it work. I'm sorry I don't have that wonderful 10C thing that Rifat showed, but Rifat, I'm going to borrow that from you. But I think we overlap a lot. The clear framing of the problem, but also clear framing of the solutions. I think simply a problem-based commission would be of no interest to anyone. And attention to diversity, we've heard that repeatedly. In the case of mental health, of course, a key area of diversity was having people on the team who were openly people with a lived experience of mental health problems. Defining the limits. I don't think any commission can address everything. So for example, in our commission, we acknowledge poverty, for example, was a major factor for poor mental health, but it was beyond the scope of a commission in the Lancet. explicitly hitching your wagon to establish frameworks and movements. And in this case, of course, explicitly was SDGs, as in the title, but also other frameworks like the CRPD, which is the Disability Convention of the UN. The attempts to push the boundaries of the field by really sticking your neck out and saying, for example, the narrow binary diagnostic model does not work. And we must reframe our understanding of mental health in a dimensional way. High-profile launch events, such as, for example, the launch by the then Prime Minister of Britain on October the 10th, which was World Mental Health Day, and then several diverse context media engagements. And I agree with Rifat, very important. Most people don't read the Lancet in the world, and therefore it really falls upon the commissioners to ensure that you are communicating the key messages in very diverse ways to diverse audiences, especially in our case, again, people with a lived experience. I'm now currently co-leading a major new commission on universal health coverage for India, and all the lessons that I just shared earlier have gone into thinking about how we assemble, plan, and communicate about the commission with our diverse audiences. So I'll stop there. And we just invite Shekhar, if we have a minute, Alan, I'd just love to have Shekhar say a few words about his impressions as well.
That would be fantastic. Shekhar.
Thank you very much, and sorry for joining a little bit late. I was on another meeting, but I was listening to all the fantastic presentations. I think Vikram, my colleague, co-editor, has presented the picture in a few minutes extremely well. What I would say is to focus exactly on the first point that he mentioned, that the Commission was contributed to by WHO and by SDGs as a framework, but it also benefited these agencies in a substantial way. So WHO was one of the organizations, and I happened to be working there at that time during the preparation of the Lancet Commission, which actually imbibed some of the messages even before the Lancet Commission was published, and also the UN, which gave much more priority to mental health than it was given earlier. So it's a bi-directional flow of information as well as advocacy. WHO, if it supports the Commission, it really lends credibility to the effort, but also WHO itself changes like many other international organizations. Thank you very much. Back to you, Alan.
Thanks so much. I have to say, I'm just so impressed with these presentations. And I think all of us are, I was struck, Vikram, by the term of reimagining, which has become a very frequently used term in the contemporary culture. And often it's used to address very significant, oftenly perceived intractable problems. Sometimes in Boston, people say wicked problems. And all of you, it seems to me, have a commitment to fundamental changes in the way we think about health, the way we deliver healthcare, the problems that are often obscured. And all of you, it seems to me, have been very persuasive advocates and activists for changes in the areas that you've been pursuing through these Lancet Commissions. So I have to say, I'm just so impressed with the work you've done and the commitment that you've had. I have several questions, but I thought maybe what I should do first is turn back to Dr. Watt, who's, as he say, at the relatively early stage of a critically important commission, and see if he has questions or reflections on what he's heard from his colleagues who have participated in this process. So Dr. Watt, is that okay if I turn back to you?
Perfect, thank you very much. I'm sort of, my head is spinning almost, because there has been so many interesting, fascinating, relevant, really helpful discussions, really helpful. And many of the points you've raised, I need to think with my colleagues in more detail and read many of the different publications that you've mentioned that are directly relevant. Some of them we are already working with, but others you've mentioned we need to look at more detail. But I would really like just to ask a couple of questions, if I may, because there's just some examples of things that came up. So maybe a question to Gene in the first instance. Gene, you highlighted the importance of quantifiable data, global burden of disease, etc. we're working on that. But one issue we also wanted to use was qualitative data on the impact of diseases on different population groups, particularly to try and engage more with civil society messaging, etc. Do you think qualitative work also can sit side by side with quantitative narratives?
Thanks, Richard. Yeah, I mean, it's an interesting question. In our commission, one way that we dealt with this is that there was a project that I didn't mention that was also part of this called the Voices of Ncdi Poverty, where in all the countries that were conducting national commissions, we were also doing videography projects. And that material went up on the website of the commission, and it's been very useful in reworking those materials and for presentation, kind of bringing some of the issues to life for different audiences. And we've actually started a fellowship now for advocates, basically from that group to get support to continue to work with us on movement building and finance and fundraising. And within the report itself, we had wanted to have more kind of boxes and panels with that work kind of in line in the report. And in the end, there's this sort of challenge with the number of figures, boxes, tables, et cetera, that you have in the report. You're gonna have to make some difficult choices about what goes there, what goes in the appendix, and how do you, and also like, would you like pictures in those in some instances, which might be helpful. So I think that that's definitely an option. I think that on the flip side, in terms of, having pithy communication about what your report's saying that seems novel, it's hard to replace numbers in that communication. And so I think that's the challenge. I think it's not universal in commissions for sure that there's like some headline quantitative statement from them, but many of them sort of strive to do that. And there may be other data sets that you can do that with outside of global burden of disease, but you'll end up, in the end, obviously there's incompleteness. And so in order, you have to do some kind of modeling in the end to make more general statements. And that leads you back to, approaches like GBD, but I'm sure there's other ways of thinking about it, but those are kind of some of my reflections on it.
Thank you very much. Could I ask maybe one more question? Margaret, you mentioned the importance of national commissions. Now, that really hasn't come across our discussions as yet, but I think a couple of the panelists mentioned the importance of having these national commissions. Now, in your experience, how did you manage that? Because having a global commission is in itself quite challenging to organize and coordinate, but then to have separate national commissions, how did you coordinate and ensure there was synergy across that? Or just be interested to hear your insights.
Yeah, and I want to say that we were inspired in this respect by Gene and his work on national commissions. The way that we approach this is very much as a local exploration of the depth of data, the specificity of the problems, the local context around issues for us of health system quality, that would serve both to inform us at the global level who just don't have access to that local knowledge unnecessarily, but also would serve to build the appetite and interest in the concepts locally. So, in a country, we might have a dozen folks from different walks of life, academics and policymakers and so on, who would be part of the National Commission, tasked with a couple of key processes and deliverables over the course of the commission. We had a pretty light touch, I would say, management strategy where we offered support where we could. We introduced concepts. We supported analysis where that was relevant. We particularly wanted to encourage, from our perspective, junior colleagues to publish in this space. So very much encouraged and supported that. They looked a little different. They had a different flavor in each country, but it is absolutely, it goes without saying, at least in my mind, that one of the reasons that the commission, I think, resonated and was widely covered by media, and again, this has come up from others as well, in the countries, in a range of countries, was not because we published in the Lancet, but because we had a global, a national commission and potentially a launch and a set of discussions about the results that were pertinent to local audiences.
Thank you, thank you. And maybe just a final observation. One of our big challenges is, unlike many other areas in medicine, there is not really a well-developed civil society movement that has focused on oral health globally. So one of our big challenges is to really foster that. And I think, again, I'll be particularly interested to read your different experiences of how you engaged in civil society organizations in a meaningful way, because I think in terms of sustainability, that is going to be clearly a very, very important message for us. So, that's an important area that I'll be particularly reading carefully in your reports. Thank you.
Gene, you had a point that you wanted to make.
Oh yeah, sorry. I want Richard. I think he's raising another top, but I'd say that just briefly, for the national commissions for R1, we were actually quite involved, and it was fairly staff intensive. So we supported countries with research assistance, literature reviews. There was a terms of reference for each country. In terms of going through a very similar process. And in the end, they ended up producing actual, reports, some of which are starting to get published independently. Malawi's published theirs, Kenya's published theirs. There have been more that have come out since. And in this sort of next set of countries that are doing their national commissions, we've had a more sort of explicit terms of reference and kind of roadmap for doing it, but we've been less directly involved and have had kind of more of a regional structure where we have sort of a West Africa lead, East Africa lead, Southern Africa lead, but it's required, a lot of support, a lot of grant support, particular in our case from the Helmsley Charitable Trust, and it sort of depends on the resources available in terms of the staffing of it, and also I think that it comes at a cost. Like I said, we took 4 or 5 years to do this, so it does make it more complicated for sure. Yeah, I'd be curious about the civil society question. That's an interesting one. If folks have thoughts on that.
There are several umbrella organizations that bring together civil society organizations from different countries, but best to engage with those initially, but also identify individuals who will be part of the commission from the civil society, because their views are really critical. At the end of the day, the commission commission outputs ought to be serving the people. So their views need to be heard during and not at the end.
Thank you.
These are all really great points. Let me pose a couple general questions. They're related to questions that are appearing in the Q&A and the chat. I'm wondering about the process. Like, have some of you who have done this had places where you met very serious conflict within the commission about how to proceed, what the most important issues were, strategies? And I'm wondering how that's managed in the context, because one of the things one might assume is by the time you get to consensus, some of the boldest proposals sometimes can be diluted. So I'm wondering how you thought about those kinds of problems as you proceeded with your work.
Well, I can start on this. We definitely had some heated discussions and debates, no question, in our commission, which was, some of our working groups were populated by folks who'd been long working, for example, in the quality improvement space, which is a very particular type of improvement, very much often focused at the clinician level, at the clinic level. But the conclusions we came to just from the data and from assessing also the science around improvement is that it's vastly underwhelming, quite honestly. Now, that was not an easy conversation to have with the very folks who led a lot of those efforts. And I can tell you it was a very tense meeting in our, set of discussions to agree together, how do we synthesize these data and what in fact it is we're going to propose for recommendations. I think the comment you just made, Allan, is exactly the kind of thing I would repeat to the group as I wandered across the groups and sort of just thought about how does one sort of push them beyond their maybe comfort zone. And that is to continually say, our goal is not a consensus product. Our goal is not a sort of just a summary of what's out there. We have to move beyond what's already been stated. That is the entire point. I challenge all of us here to be bold together. That is not the lowest common denominator, but a level of boldness where you can sign off. A lot remains to be done, and a lot of science remains to be done to justify and localize and contextualize many of the recommendations. We don't say we know all the answers. We agreed that we would instead point to directions, the direction of travel. Here is the types of things that would need to be done and studied, not necessarily this is the solutions, and that was another sort of strategy that we used. But I completely agree with you. One of the dangers is that you end up with sort of a, received wisdom, which is actually not the intent.
Yes, I would concur with that. It's very important that the commission does really push, or commissions push the boundaries of knowledge as well as practice, because we're trying to address major issues. Clearly, more of the same is not, will not do. And tensions will arise. And actually, I think tensions are healthy, especially creative tensions, to really try and focus the commission's purpose. But sometimes there are some major differences because one is maybe changing frameworks or reframing existing approaches. And with that, one can use approaches such, for example, on one occasion, we developed a viewpoint that was complementary to what was being done, but reflected view of some of the individuals without leading to a major breakup of the commission. So I think one has to use different approaches and techniques. But I think tension, by definition, will be there because you're pushing boundaries from very different perspectives.
That's really helpful. Shekhar.
Just wanted to share the experience of some difference of opinion. For example, when we wrote the commission, we emphasized the reimagining part, but also the task shifting and task sharing approach to providing mental health care. And we did have resistance from some of the members of the World Psychiatric Association who really believe that it's a matter of a specialist and not for trained non-specialists. And we did have some tension there, including during the review process, because the Lancet actually sent the draft to people who were from that kind of background. And we had to really come up with enough reasons and strong reasons to say what we did. And we did manage to do that, which I think was because of the collective wisdom of the group that we had. And I think it eventually worked out well. But it did require some maneuvering and some marshalling of strong arguments. When I have the floor, I just wanted to very briefly touch upon another question. How did you involve WHO and to what extent did it succeed? I think there is a fine line in involving WHO. If you really ask WHO to author the commission, you will not say anything which is challenging. So we have to avoid that. But still involving some of the professionals as commissioners, while a footnote goes to say these are the views of the individuals and not of the organization, was a very good strategy. So we actually involved WHO, but not WHO as an organization, but people within WHO who were willing to make that kind of commitment. And for us, it worked out very well. Thank you.
That's really helpful. I mean, these commissions really raise a critical issue about the global governance questions, and NGOs governmental operations and systems and their relationship. And it strikes me that the independence of the Lancet Commissions has a sort of special place in that ecosystem, if you will. So there are some other really great questions coming up. One of the frequent ones, I should say, is really focused on Richard and the commission he's involved with, is how do you integrate something like oral health into global health indicators, measurements of the burden of disease, healthcare delivery. And it strikes me, in almost all of the instances in which you've talked, all of you are working against deep historical and cultural legacies of expectation, of problems of stigma, of problems of invisibility. So one of the questions, we have many people from the dental school today in the webinar, is, are there strategies that many of you would advise about how Richard's commission can have a broader impact into other perspectives on the burden of disease and prevention and health? Anyone want to take a stab at it? I think some people were looking at your commission, Margaret, and thinking, like, in health systems, do we normally include oral health or dental medicine? And is that a strategy for thinking about the integration of broad health indicators? So,
yeah. That would have been a great thing, Allan, had we spoken with Richard and colleagues at an earlier point. I think we did groan, I have to say, under the weight of kind of the health challenges that we took on. I know that there's even discussion in the commission whether we have any ability to tackle mental health. I think many of us felt that that's just an indivisible part of health. I think that the challenge that we faced around kind of scope was data availability. We were just really shocked. One of the big findings of the commission was just how little data, and again, Vikram and Chikar know this exceedingly well for mental health. Where we could, we always included mental health, and I still show the graph that talks about minimally, data that are now 10 years, over a decade old, minimally adequate mental health provision to people with depression or anxiety. It's shocking. They are the worst performers on our graphs typically when we counterpose them against HIV or other kinds of conditions. So just to say that we had great ambitions, a shortage of data, and probably could have taken an even more inclusive approach with more folks on board. Because I completely agree with the premise of Dr. Watt's commission that these are absolutely essential and linked issues.
All of you are. Yes, please, Richard.
Maybe also I could maybe come back, and I suppose in some senses, reflecting and listening to the other panelists, with the experience of the Lancet series, with hopefully the experience of the Lancet Commission, in some sense it's our responsibility in the oral health community to raise our flag and engage with the panelists in different fields to demonstrate the relevance and value of what we're talking about. So rather than sort of feel we're neglected and no one's interested, it's actually our responsibility to engage and use our data in different ways. And just one example, Allan, you mentioned about oral health being a sort of biomarker of disadvantage, etc. Well, some of us have used the expression of the canary in the coal mine, that dental disease in children in particular is one of the first indicators of a social environment that's hostile to health. And it's an easy marker to measure. Information like that we need to share with the broader global health community and demonstrate the resonance and value of our field. So I take that as part of the process that me and my colleagues will move forward with.
Yeah, that's really helpful, and I think a very important idea. Gene.
Yeah, Allan, one thing I was just sort of reflecting on, obviously in our commission, we were concerned with non-communicable diseases very broadly, including oral health. And I think that Alan's point about inclusion in indicators, and I think there's a great opportunity for that. I think looking at where there are gaps in World Bank kind of indicators, other kinds of indicators. But in our commission, one distinction that we found, I think, useful, and I think this was in a way taken from mental health in a sense, is like sort of this distinction between common conditions which are generally of lower severity for the individual, compared with more severe conditions which are less common but are much more consequential for the individual, and the importance of that distinction from an equity standpoint. And I think that I would be careful not to neglect the severe less common elements. And I think that both stories can sort of be told, but I think that we tend sometimes to make arguments in terms of prevalence. There's other kinds of measures that obscure that equity dimension of it, and we of course are very concerned with equity in the sense of priority to the worst off, the world's poorest people. But I think it got us kind of interested in this more general point about equity and priority to the worst off. So I think in your commission, you're going to have that tension about which story do you tell, and how much weight do you put on each. And I think I think a lot of commissions, that is an ultimate dynamic in them, be it diabetes in Africa or mental health or non-communicable diseases more broadly. And it's an issue that doesn't come up as much, I think, in sort of the infectious and maternal and child health world, because in a way there's sort of a happy kind of coincidence where you have like very severe yet common conditions in that world. Like, there's a lot of malaria, and it's horribly consequential for people who get it. But we don't really think of that spectrum like, yes, there are colds, as well. And I think like the coronavirus, thing has kind of brought our understanding of severity of infectious disease more into the fore. But particularly in MDG era, we're kind of dealing with a lot of severe and common infectious, or to a lesser degree, like maternal conditions. I mean, some might disagree with that analysis, but that's a thought that I would have for you.
I think that's a really useful thought. And in our world, because, for example, oral cancer, cancers of the lip and oral cavity in Southeast Asia are exceptionally common, a major public health problem, that major cause of mortality. Whereas in some parts of the world, they're relatively uncommon. So we have got conditions that have that significant impact at the individual level. And in Africa, Noma, and the major infection that can cause disfigurement, death, not very common. We don't have much data on it, but in terms of impact, is hugely important. But we have to work out the balance between the very frequent and common conditions versus the less frequent but of major impact. So useful point to make.
But I think there is merit in addition to what Gina said. I think one should look at the relative burden of oral health, obviously the equity issues, human rights dimensions. But I think looking at the historical antecedents in relation to health systems evolution is critically important, because in many countries I worked in, oral health is fully embedded in primary healthcare. It's really integral to primary healthcare. But there are also other countries where oral health is completely disconnected from mainstream health systems. It will be useful to examine why this is the case, and how oral health became separated from mainstream health system, and why it still is fully embedded in primary healthcare in many others. And then use the lessons learned for those countries that are developing their health systems and progressing their universal health coverage to ensure that oral health does continue to be part of universal health coverage and is fully integrated with primary healthcare.
Yeah.
These are such important ideas and points, and I'm a bad timekeeper, because when I'm learning so much, I really hate to end a discussion. I'm so grateful to all of you because of the work that you're doing and the work that the impact that it will have. And it's really been a pleasure to get to sit in on such a important conversation. And of course, I want to wish Richard Watt the best of luck with such an important commission that he's currently co-chairing. So let me turn it back over to Dean Barrow, and thank you all again for participating.
Yeah. This has been a phenomenal conversation, and I and all of our participants, I'm sure, have learned so much from all of you this afternoon. And Dr. Watt, thank you for joining us and sharing with us the launch of the Lancet Commission on Oral Health. And I'm hopeful that we can rely, pardon me, on all of you to help Dr. Watt and the Commission as we continue to progress in the activities of the Commission, and help us continue to raise the profile of oral health as we think about health systems and how we can improve health, particularly for disadvantaged populations. Although oral health may be very prevalent and not always severe, to quote Gene, if we think about keeping people healthy and take a preventive and primary care approach, we can keep people healthier, help control diabetes and some other conditions through a common risk factor approach. And I'm sure more of that will come up in the Commission. The hour has come, so I don't want to detain us further. I think I could talk to you all afternoon, because I find this really exciting stuff and appreciate everyone's time, and do hope that we can keep the conversation going in the future. So thank you all again, and many thanks to our participants for joining us today. Bye-bye.
Thank you.